and welcome to the 2020 Brain and Transcranial Photobiomodulation Virtual Summit. I'm your host, Dr. Joe Doduro. I'm joined by Anya Futchenbush, right?
More or less.
Huh?
More or less, it's okay.
She's the CEO of the publishing company, and she's founder and president of the Medical Association College for Laser Phototherapy in Munich, Germany. She's a member of the outreach committee for the World Association for Photobiomodulation, and she's a highly recognized trainer in the field of veterinary medicine. It's my pleasure to have her as part of the virtual summit, and so thank you for attending, Anya. Okay, and we also have Dr. Thomas Henning. Dr. Thomas also joins us from Germany. He is currently in practice of psychotherapy, addiction medicine, holistic medicine in Stromberg near Munich, which I'll show you in a second. Thomas was a general practitioner who specialized then in psychotherapy in 1997. He's run a successful practice of psychosomatic medicine, addiction medicine, and clinical hypnosis for over almost 20 years. He is one of the first to use the transcranial photobiomodulation in a psychology practice there in Germany, and I look very much forward to hearing his presentation. Thank you for being here.
Thank you.
Can I show everybody where you guys are from? Oh, here we go. Let me go. Oh, there's a nice lake there, huh?
Yeah, a wonderful lake.
Well, you know, as I said, I was spending a lot of time down in that, but it's tough to see a German that says somebody's got a more beautiful place, right? So that's great. Thank you for being here. Anya, you've been working with photobiomodulation therapy and all this stuff for how long? How long have you been investigating this, Anya?
Well, I'm in this business since almost 20 years now. I started more or less right away photobiomodulation, or better to say, light biology. Photobiology has been my favorite topic all my life. I started very early with this, and then even later on, I got to meet photobiomodulation as a therapeutic tool.
Therapeutic tool?
Yeah, I'm interested in photobiology my whole life. What's the meeting between life, matter, and light? And then later on, I got I got acquainted with laser phototherapy, and then I stick with it, which is almost 20 years now. Yeah.
So I like that. And you've created an entire learning platform for people to
exactly. We
get that education, right?
Yeah, we founded a college. It's an academical college about 10 years ago. And it's for all therapeutic directions. It's veterinary medicine, and it's human medicine, it's dentistry. Today, we try to help all faculties in how to apply PBM.
I think it's great. I mean, and it's through my connection with you in the college and the great work that you're doing there for education that you put me in touch with Dr. Henning, right?
Exactly.
And Dr. Henning, we did your intro, and tell me, I mean, I've been told that the German, people, their therapeutics, can be a little bit rigid, but here you are, a psychotherapist, an addiction specialist, and you decided to put light on someone's head. Tell me how that happened.
Well, in a very hard night, I looked to a YouTube video and I saw a very nice congress with Paulo Cassano and Margaret Naser. and I was absolutely flashed about the results he was presenting. And so I started to contact Kolorg and Anja Fürchtenbusch, and we talked about, and she had all in this time already connections to France, to the creator and technical director of Biophoton. And so I got my streamings S3, which I now treat for a year. And after the first, when I started, it was a great thing. I had a lot of programs, and I tried to include the programs with my patients. I started with a little bit dermatological, a little bit orthopedic, a little bit pain, and after a while I started as well with headache pain and with patients with dementia, cognition, and psychosomatic clients.
Mm-hmm.
And because the first steps were very, very successful, I opened a database and started to make a little bit a data collection for my patients and to see how it is developing during my modification and during my working with treatings.
So you were you kind of tippy-toed in, though. You kind of went slowly before you treated the brain. You kind of went slowly before you treated
yes.
the mental conditions. Why is that?
I didn't understand right, I think.
I'm saying you saw the video by Paolo Cassano.
Yes.
And I think that was an amazing video also.
Yes.
And his explanation was really great. But then once you got the actual device, you didn't start treating depression right away. You started treating the skin, and you tried to do the ankle and everything. Why didn't you start treating it right away in your psychological?
Because of two patients which were very disturbed in their psycho connections, and the illness was pretty increased, and they didn't get rid with the medication they had by a psychiatrist and from me. And so I asked them whether we could try it with light. And with the first steps we did, and we did it very, very carefully and very slow motion. The increase within a week was enormous. It was, they both came, and that it is impossible to believe what it is going on by this light. And so I started to project my way of treatment, which I will later on show you.
Perfect. Well, let's go to the slides, and I'm sure I'll interrupt more. Go ahead. Let's go to your slides. So Dr. Henning's going to talk about the treatment of depressive disorders with transcranial photobiomodulation, continuing one-year practical case study or case series. Now, he's a doctor and a PhD. I think I left that out, that you're a PhD. You're also a teacher, right?
Yes, so I am.
You teach at the nursing school, and what do you teach over there?
I do the whole psycho subjects, from neurological to psychiatry to psychotherapy. Wow. And addiction medicine.
Well, we'll talk about that as we move forward. Thank you. Move forward. Go ahead.
Okay, Joe, thank you for invitation, and Anja, thank you for making the contact. I will present you a very small case study with the application of transcranial photobiomodulation on depression. My time scale of the study is the March 2019 to the March 2020. I have a very special device of PBM. I have the Triwings S3 from the firma Biophoton from Saint-Alban, France, nearby Bordeaux. The honors we had already made, how I came to the PBM we made as well. And so I will start what I learned immediately about photobiomodulation. The application of the PBM shows positive results right away, and I created a database really to get on. And the significance of photobiomodulation therapy for the practice after 1 year of use is important central treatment method. Within 1 year, I have treated a total of 85 persons, which is for a normal psychotherapy practice a lot of patients, and there are patients from years before coming with disturbs and trying the method with a wide variety of diseases. The motivation is still positive today, not only for me, but as well for the patients who use it. My case study as an overview, I will show you a number of cases and proportions of depression types after the ICD-10, which is similar to the DM4, 5, or 7. I show you up how I select patients, share you the PBM therapy in my total scale of treatments, the instant results, which is during a basic treatments, and then the treatment planning and treatment structure. The evaluation of the therapy after completion of the basic treatment. At the end, when is continuous further treatment indicated? My case study, my total number from 85 or 41, which are included because of the depression diagnosis. I divided this in first diagnosis, this is the main diagnosis of depression, and the second, which is the first main, can be pain, can be otherwise things. The 41 divides in a total of 16 and 25, male and female. In the first diagnosis, there are less males and more females. In the second, it's equal. I show you this in the picture. The whole situation, only the depressions and the other diagnoses which were threaded. The main diagnosis, you see that the women have more effort to change. The men are very anxiety about, have many anxiety about using a new method, and therefore it is for me a very good thing that after a while in the second diagnosis this was changed totally and it's becoming equal. Which patients are eligible for the treatment of transcranial photobiomodulation? First of all, those who are difficulties of no acceptance or with the medication or off the medication. Others, the patients are with medications but dissatisfied by the primary medication. Patients prefer transcranial photobiomodulation as an alternative to the medication. For me, it was important how do I select. I do this in a very basically individual assessment. I look forward with good tolerability of the medication, then I normally use less PBM. For the individual difficulties of the medication, there is an enormous thing for the patients to have photobiomodulation as a new option. In Germany, and I think worldwide, a great proportion of patients suffering from polyallergy and those of reactions with intolerance and various kind of increasing. These patients do not want any additional medication but want possible stabilization.
Polyallergies. You're saying, what does that mean that they are polyallergies? They're going to have a negative, they're allergic to drugs, or they're allergic to...
No. They are allergic against trees, flowers, corn. They are against medicine, against lactulosis, fructosis, all this stuff, the whole large empire of allergia.
Gotcha.
Okay. In my studio, I have currently about 1/3 of my patients receiving PBM treatment. My treatment scale contains not only depression, that is something I want to obtain. I'm almost half of the cases I consider PBM as a good addictional therapy, or as the only measure of suggestion to the patient. Patients are either privately insured or self-paying. That is important because I'm not the so-called German medical who is paid by the insurance.
Oh, not the social state-run one. Very good.
Exactly. For the first, it was a question for me, how do I make an evaluation scaling? So I first made the successful fail scaler, which is a common meter using in medicine to assess therapeutic successful or failure. So the successful and failure values starts with -3 to 0 to +3. After each trans-PBM session, the patient and then also the therapist independently evaluated on this basis. The results are compared with each other. In my case study, the self and the therapist assessment largely coincident, which I was very glad about. My evaluation scale is increased after a while. Before each consequent treatment, the evaluation is based on the CGIS scale, which is the Clinical Global Impression Scale in Germany from 1 to 10, I think in US 1 to 7, but it is similar, I think. The general assessment of the quality of life, including the psyche and the body.
How many measures is that, without going, if you're not going to show it? How many questions is this scale?
The scale is
just one question for the whole thing?
Yes.
Okay.
The immediate results are were very positive. The results within the first 3 treatments I call the immediate results. The evaluation methods is as before that, the successful care from -3 to 3, consequently positive feedback from patients in a subjective way. In 80%, and that is something you see here, is twice positive in the first 3 treatments. It's only 10% neutral outcome and 5% with positive 1 outcome. Therefore, we have 85 positive outcome and 10 neutral and 5% really negative, which is decreasing on one point.
Wait 1 second now. Wait 1 second. 1 second, please.
Of course.
So, this is your immediate results. So your success scale and everything like that. So you're doing a therapy. And when do you do the post test about the results? How long after you do the therapy on the brain do you get this response?
The response is immediately after the treatment.
So they stand up and they say, I feel better.
Yes.
And that's what you're asking them.
Yes.
Very good. And it seems like that. The funny thing is that most of them are very positive afterwards, right?
Yes.
So that's what we can say. Very positive. I feel better. That's what they're telling.
Yes. But they learn in the first treatment that there is a possibility from zero up or down, and the difference is too positive.
Mm-hmm.
They say it is twice positive than at the beginning, and so it increases continuously.
So this is after 3 treatments. So you've asked them 3 times.
I've asked them three times, and the middle is then this result.
Very good.
The treatment planning. I'm normally have there is German law and order, and therefore we have first for the beginning an informatic talk with the rules of protection and conduction with laser. Then there is a small booklet which I created where the patient has to sign a question to his internal diseases or something like that. Then the acceptance of the treatment, and then the acceptance of the costs.
That would be like a consent form in America, and I think that's an important field. That if you're going to put a therapy, a new therapy onto someone, they should have understand what's going to be happening, how this is going to work.
Exactly.
This is how we're going to do it. Do you agree? You understand the risks? I think that's very important. And, I know that there's some strict standards in when you're a medical doctor in Germany to do these things. So I think that's an important thing. But we might want to, we should have a document like that. We should for everybody.
Then a PBM treatment unit for depressive patients consists in my practice 6 individual sessions as basic treatment as a basis of assessment whether the transcranial PBM shows effects. The first and the second appointment should be in the first week if possible. The third and fourth appointment should be in the second week if possible. The fourth, fifth and sixth appointment should preferably be received with about 70s between treatment. If this is possible, there is a variety from 3 to 5 days in the 4th to 6th treatment. So the whole period is coming up to 5 to 6 weeks in totally. My guidelines for the transcranial photobiomodulars is how to do. I start the treatment with low doses. First treatment, short treatment time is about 12 to 36 minutes and is corresponding to 1 to 3 programs of the biophoton tree-wings. Contains present therapy programs, which I cannot change a lot, but I can change a little bit in time and in intensity of fluids. Always keeping with the patient contact, questions how is the condition, are there side effects, are they feel good, and having the contact continuously. At the beginning of the following treatment, assessment with Sigis scale And for me, I do normally a Hamilton scale with 30 points as a self-assessment, which is not documented, but which I need for the continuing of the treatment for myself. The increase of the treatment time always only in the case of well-being and good tolerance of the first treatment. So there's a small informative question, then the acceptance of the patients to the next treatment. Second and third treatments with 25 to 40 minutes, as well 1 to 3 programs divided. I show you up here one of those program lines, which is winter depression 12 minutes, PBM 10 minutes, and relaxation program with 8 minutes. The position of the patients depends how the patient feels it. Some are sitting on a chair, others are lying on a bed. Yes, and I try to give them the light treatment from right behind of from the start of the medulla ossa up to the front to the front schädel.
Well, tell him, Anya. Tell how you're putting it on there. Go ahead.
He said he puts it on the skull, on the forehead,
From the forehead to the rear.
From
you're
the
moving
forehead
it within that. When he
Yes.
changes
to the occiput.
when he changes the time, or when you reset the program, you'll move it to a different area. Is that right?
No. This machine is doing this continuously by LED light out of the program and out of the informatic program screen. So you have a stable position of the tree wings from the front over the main head to the rear of the head.
It moves. It
is firm.
The head of your LED thing moves like this.
No, I show you this in just a moment.
Okay.
This small picture here,
Mm-hmm.
you see this angle that is division in 3 parts.
Mm-hmm.
And there is a rotation head, and so I can bring this in a position that this is right in front here,
Mm-hmm.
and that is down here, and the person is sitting here with the head, and the light is going all over that.
So does it
It's
go
3 rings, Joe. It's
like
3
this? Does it go like this, or does it just make
Yes.
one cycle? Or does it go like
Yes,
this?
Yes.
like a casket.
Like a helmet.
Helmet, yes.
I like a helmet, but not really a helmet. So does it make one move and
No move at all.
but just,
It's
just
fixed. It's like it is in a position. It is like that in a position.
You think it can cover from the front to the back of the head? It doesn't.
More or less, you can from the front to the base of the scalp. Yeah.
Go ahead. Thank you.
Good. As we already said, the intervals are always shorter in the first 14 days, and the last 3 day treatments are longer. The adjustments of the treatment time depends on the individual well-being of the patient. I do not increase the treatment if some side effects are coming up or something like that. Yeah. In principle, no more radiation is necessary. 4 to 6 treatments, 40 to 60 minutes, 3 different programs with 20 minutes, 1 program, and the increase of during the whole time. The individual composition of the programs and times, even backseating of the treatment times occurs. The last 3 treatments take place in individuals in intervals of 1 week, and the adjustment of the treatment time depends on individual well-being for the patient. Total treatment per period about 5 weeks, maximum 7 weeks. The basic treatment of 6 radiation sessions ends with a discussion and evaluation. The evaluation is again 3 scales: assessment of general quality of life according CIGIS, self-assessment by the patients in school grades 1 to 6 as it is in Germany, external assessment by the therapist Hamilton, and successful failure values as well. Good.
So the therapist, go back 1 second for these, 1 second. So the success and failure values are just you at this point, or did the patient get to make them?
We both do this. We both do it, yes.
That's what I
First, I will do this during after the talk with the patient, and after I had the Hamilton depression scale in mind, which is is absolutely only for the therapist.
Okay.
The successful and failure value is one of these 3 basic evaluation methods.
Very good.
Following up treatments after basic treatment, that is a question which comes very, very soon up. I always have there a new informatic hour where the assessment by the patient and the therapist will be discussed on the questions which following now. The first of all is, does the patient have an objective benefit? Is there a measurable improvement? Is the treatment well tolerated, and are the subject's reasons of the patients? And there, I don't know whether shall I give an example, for example, or is this too large for the time? I don't know.
So you're saying that you do an assessment every week?
Yes.
So we'll have weekly intervals of you reviewing these parameters. So I think it's great. I think we can go forward.
Okay.
We'll probably have an example later. Go ahead.
Okay. For me, it is always important that after the 6 basic treatments, there is at least 1 week of pause, of interruption. The treatment time and program always individual orientated towards diagnosis, and the length of further treatment is always individual, made in the discussion with the therapist and the patient together. Well, my summary on the outcomes. The conclusion: fundamentally positive results in the majority of cases. In 80% of the patients, improvement after ending the basic treatment, 6 treatments overall, was confirmed by the number of +2, and 5 of the patients with +1. So we have 85% which are in the positive way.
Wow.
Less than 2% slight effects that led to the discontinuing of the therapy. Tolerability of the rated is highly positive by more than 85% of the patients. For me, very astonishing, but on the other side, no. It is 60% of the patients who take advantage of the off following treatment after the basic of 6 sessions.
Ah, that's a...
And about 30% of those take advantage of the of continuous regular treatment at intervals of 1 or 2 weeks, and a great number is still continuing.
Wow.
The last long-term group compromises that the programs are on the maximum, and the time is as well on the maximum. They start with 3 times 16 minutes and continuing to 20 minutes, and they come regularly once a week.
Nice.
Yes, that is the first step, and I think for our device of today, it should be stopped here, because the next part is more the practice treatment of how I do this with the retrievings and how I get the information
You can
for
continue.
me.
How you adjust the parameters.
Go ahead.
Yes.
Continue if you like.
I think we stop here, huh? Anja?
From here, now on, they are coming all the parameters.
I like this, that you kept the data. I like that we have this, that 85% of the people that you treated had a positive effect and they want to continue. So the thing that basically it's like, is everything going okay? Yes, and then you continue. That's how you kind of did the practice, right? The patient-driven outcome. They like it,
Yes.
keep going. So do you have any idea of what the outcome was with people who were on the drug therapy and people who were not on the drug therapy?
On this basic demands, I didn't specify this in the moment.
I just wondered if you just clinically said, oh, well, this person has been on medication for 5 years and she did not have good results. Did you find
that
any?
That cases are included, yes.
So it really didn't matter if the percentage of them that had the drugs, they still got better, right?
Yes.
So that was the thing. What did you notice? I know you've gathered some Hamilton depression scales pre and post, some of them. What did you notice about that? Because that's what Cassano, that's what everybody's been using, well, Schiffer and those guys. They used the Hamilton depression score, and I know that's why you used it. What did you, have you seen any changes in that you want to talk about?
Well, I have seen a lot of changes in this, but my problem is that because of my doing as one-man show, I'm not able to document all my intentions. I made a very and it is my first database which I made in this manner. I up to now not have documented the values of the Hamilton score.
You just clinically, just your impression
yes,
at the data, it's going good, right?
Mm-hmm. That's right.
Because the people are getting better, you know?
Yes, and that is important. Now,
you're going to show us some cases, and I understand that there's a lot of differences in the diagnosis, the severity. So first question, did you see any difference between the people in their outcomes between the people who had primary diagnosis or a secondary diagnosis? Did that change anything?
There are differences. There are differences in the. I think that if you are having cases with a very light depressive disturb, there you can use less treatments for having a very good result already, and a very small group of those is having the necessity of continuing and follow-up treatments. From the intensity of the depression of a middle graded to the hard graded depression or major depression, like you in US say, there is a great difference in the need of treatments and of the
follow-up
fluence and the times you use.
So you do see that depending on the severity, the duration,
yes.
and intensity of the depression, yes, you modify your parameters to try to match
yes.
that.
Yes.
That's what you're saying. Had you ever treated, because the secondary diagnosis people may have things like back pain or
yes, of course that is a large
right,
that is a large group with so-called psychosomatic pain, yeah, right, which is back pain, which is lumboischialgia, which is arthrosis cases, and which are treated on a second hand as well. Yes?
That was my question. So are you treating them with photobiomodulation on their back or their knee or their hip and the head at the same during the same period?
No, not in the same period. I do this one behind the other. Otherwise, the time management is not makeable.
Makeable. So what I'm asking is, you take if they have back pain and it's secondary depression or anxiety type of thing, you'll take care of which one first? You take care of the brain first?
Normally, if the patient has an acute pain, I use PBM for the pain, and in the second look, I go for the depression, because I have to treat the acute situation.
That's what they're paying for. That's what they're coming in for. Because yeah. I wanted to kind of understand if, one thing we know that if you put light on the body, it changes the brain. So some of these people may have been influenced by having some body photobiomodulation. The next thing is that I was wondering, since you do psychosomatic medicine, what do you treat first, the psycho or the body? So the soma or the psyche, in your opinion, which would you treat first? And that's the one that has the biggest complaint, right?
Exactly, and I think if you're making this as a doctor, as a medical doctor, you have the possibility to decide what is for you the first step and then the second step. And a psychotherapist who is not a doctor has this possibility not to do.
Yeah, yep. And, taking care of these people, you did psychosomatic, so it's obviously helping with the depression, but you're also a sexual therapist, a sexual consultant therapist, right?
Yeah, it is a normal thing for me as a psychotherapist to talk about sexual disturbs, and as Casano already made sure that light therapy is increasing the libido and getting sex again in shape.
So you're saying that you had the majority, in overall of your practice, but in this case, you had a majority of female patients. You're talking to them, you're getting good quality of life. So in this group and then in the total group, you found an increase in libido and sexual desire and in sexual pleasure with these people, just like Casano had noted. Is that what you're saying?
Yes, exactly.
What would be the percentage of the of the people or the females, what would be the percentage that had this increase in desire or pleasure? What would you say, what was the percentage? And just a guess.
Phew. I would say 45%.
And then
maybe a little bit more, but the strange thing is man doesn't talk about this.
Yeah, I'm saying it's the same thing. I mean, if you don't, you're a perfect study because your practice includes this, and it's not so much taboo as it is in America. I mean, it was amazing that people went to the doctor and actually talk about this. So you've captured a change which too many clinics and doctors might not get. The chiropractor, if I'm putting therapy, photobiomodulation on a person, I'm a chiropractor, they're not going to pull me aside and say, hey, doc, I'm feeling a little bit more. This has been anecdotal for years, for decades. Here you
yes, but I want to correct you. I think the Germans are not so open-minded in sexual things as you may be thinking. I have read in a journal that 80% of the psychotherapists never speak about sex with their clients, which I do not understand for nothing. And I think it is one of the most directionally going things to find disturbs and to find problems which are underground. Yeah,
I agree. Well, you gave us some more documentation. Let's go to the next slide then. Go forward. There we are.
Well, I first made specifications in light therapy, severe therapy, light recurrent depression, moderate recurrent therapy. You have here the first diagnosis, and the female that is not possible to see here. The second is light depressions, several depressions, light current depressions, moderate current depression without and with psychotic syndromes, which are in remission as well.
Okay.
Then we have the first diagnosis of the males and their after light, severe and light current depression. We have moderate current depression, dysthymia and bipolar disorder. The dysthymia group is very particular. That is a group of three cyclistic sportives. I don't know, cycler, who bicycles, they go by bicycle, by sport bicycles, and they are all three go for long distance, 90 to 250 kilometers a day. And they are very, very einsam, lonely in on those journeys, and therefore the dysthymia is increasing very, very fast. And
what is dysthymia? Describe that for
dysthymia is normally depression disturb, which is loneliness, unhappiness, and sleeplessness. And the lonely hearts, as a lonely heart disease, as I say in Germany. Normally, it is the most important depressive disorder, which occurs to lonely women over 45, not fertile, fatty, and very unhappy.
Well, I mean, we're in quarantine. I mean, That could be the new thing, the new diagnosis of the world. Loneliness.
Yeah, loneliness.
Loneliness. Go ahead.
Yeah. I think we skip to this imagine of the light depression, so I can explain you a little bit the outcome. Can we get off this imagines on the right?
On the slide.
On the slide, can we give them another position?
Let me see. Put us away, or what do you want to?
Because I need the last line here.
Well, we see it.
I'm not. Maybe just. Oh, now I can read it. It's good. You see here
the
timeline, and there is an
Schützen.
You see that here the head area is under the tree wings, and the programs are relaxation, photobiomodulation, and winter depression. It is only the name of the programs, and you see here the fluence, the energy, and the time. So in these cases, the augmentation of the time is very, very fast to the highest end, and you see here from the PBM fluence with 114 and 70 in 20 minutes. And you see that there are always two packs of programs, for example, relaxation 40 and winter depression 20, winter depression 20 and PBM 20. There is a difference in the fluence beside A and B. And you see here the overlook to all that treatments with the light depression episodes I made.
Okay, good.
Then.
So there we go. Go ahead.
Okay, just a moment. Here I made a circle graph for demonstrating how important which program is. You see, for example, here the winter depression B, which is only once used, and you see, for example, the circulated manner of the PBM, which is as well only one times made. Otherwise, it is, for example, the PBM 12 is 3 times used, and so it is and very important. And the PBM 16, which is a central program, which is in most of the parts a central program which is used.
So this was one patient with severe depression, and this is the applications that you gave?
Exactly, yes.
Got you.
I think it is too annoying to explain this for all this for all these things. I think
I got you. But I'm saying is, if you were a statistician, if you were that kind of practitioner, that all that stuff can come out. But you're just making the point that you varied the program depending on the patient and their complaints, and you modified the treatment and you moved along. And that after that, you kind of look at everything to try to make a correlation so that you can,
exactly,
as a practitioner of 20, 30 years, you'd be able to say, maybe I think we need a little bit more, or a little bit, that's you. To make a correlation for other doctors with a different machine, that's a different story. But we understand that from this, we understand you're using significantly low power and it's going into the person on different rates, and you're modifying it as the patient needs. And I think that's what the takeaway is, that people, practitioners, therapists who are trying to do this, or people are doing it on themselves, that's what they got to kind of do. Have a lot of options and then kind of move through them depending on what you feel, right?
So I am agreeing absolutely with you. The German variety, and this is a collina in Tuscany, which is a place of big fortune and forth, yeah.
Strength.
Oh yeah, that's nice. At least they kept the tree there. You have a lot of beautiful places in Germany also.
Yeah.
Let's stop the share and let's just do a little combo here to tighten it up here. You basically, are using the instrument that you have to vary the dosages and the programs and everything like that. And that's kind of, people need to understand what their machine does and kind of move forward with it. That's what I understand. And I think you did a great job. How do you see this moving forward, Doc? I know we have Anja who's helping to educate practitioners and all different people on the different, benefits and even some of the protocols that you're putting together. I could see how that would fit, into the school. But how's it going introducing this to other doctors, other medical doctors, other nurses, other psychiatrists, the people that you are influencing? Obviously the patients like it. They're getting better. What do you think about the community at large?
Well, I think it would be a great effort to lots of doctors to have such a great trainings as well. But we have a very big lobby of pharmaceutical industry, and our lobby isn't such rich and not so potent like it is in other fields. And
we are lonely fighters,
Yeah, lonely, right.
Don't get any support from big pharma, so you know how it is.
Well, I think that you're a teacher. Both of you are teachers. Both of you are educators. When we have an opportunity like this to speak to the public or the practitioners that are getting online, the message is that this stuff works. Give it a try, right? And then this is the way you do it. Give them some parameters, because you see what you're up against. It doesn't matter if you're selling pharmacy or light therapy. They got to buy it. Someone's got to say, I'm going to give this a try. So
yes, but here we are. We have the problem that the new generation of low laser light therapy instruments. It's a great amount of money to give for having this machine and for then selling it to your patient, and that is something which not is very easy for lots of doctors, because we have no education in economic basic decisions. Yeah,
correct. That's correct. They teach you how to be the doctor, but not how to sell something that's not going to be covered.
Exactly.
You have to make, you have to recuperate, and the patients see the benefit. The patients see the benefit once you can present it to them. Go ahead, Anja.
Joe, and also it's like the patients, they have to cooperate, in the sense they have to come to the clinic on a regular basis. They cannot just intake pills. They have to cooperate. It's a different style. It's a different way to...
Yeah, I think that when you're doing something as particular as, as Dr. Henning's doing, you've got to pay attention to that versus people that can do have the devices at home and things like that. So
exactly.
I think that by looking in the future, we're going to have more education, more cooperation, get the word out, tell the people about this, that it works, that it's, very little side effects, and that maybe we can get more people involved. What do you say?
Exactly, yes.
So we do.
That's what we're doing. Thank you all for your time and presentation today.
Thank you.